Thank you very much for that warm welcome. I appreciate it. It's kind of interesting, in the last week, as I was getting ready for this, three things happened that impacted how I wrote this talk. Now, last Monday, Margaret Thatcher died. On Wednesday, my best friend, a man who's also in his late 60s, I know I don't look like I'm in my late 60s. You don't have to say anything about that, but thank you. Told me he was going to have his first grandchild. And finally, Sunday the 14th marked the 10th anniversary of the completion of the Human Genome Project, the mapping project. And on Monday, just 2 days ago, the US Supreme Court heard a case that may impact the whole future of biotechnology. Now, for reasons that I'll explain as I go along, these disparate events may be related. So I want to thank the gods of speechwriters for what that great comic W.C. Fields used to call a most fortuitous circumstance. Now, let me start off talking a little bit about my friend's grandchild. The child is due in December, and that's 2 months after we begin enrolling something like 20 million people who are supposed to start in the Obamacare insurance exchanges. Now, I know my friend is concerned about what kind of world the child will be born into. The cost of American health care will be somewhere north of $2.8 trillion this year, and that represents at least 18% of our gross domestic product. But this speech is not about gloom and doom. Now, I know you've heard this before. Healthcare is like a three-legged stool. One leg is about access, another is about cost, and the third is about quality. And the theory goes that you might get 2 of these 3 legs, but you won't necessarily get all 3. Now, if the exchanges are fully implemented, and that's a big if, by the way, but if they are implemented, we should see access improved, cost increases may or may not be slowed, but, and we heard a little bit about this in the last panel, there's much concern about what happens to the quality of care in the new environment that's coming. And I know that quality has been a major concern at this meeting and for your organization even long before that. So, like in the last group just before me, I can tell you that a major topic of discussion where I come from and what I've seen elsewhere in the country is what will happen to quality when millions of people who now have no access to health care, or maybe getting it for the first time, or haven't had it for a long time, come up against a stark reality that we're facing a shortage of primary care physicians, nurses, and general surgeons. Now, Massachusetts faced this problem of too many patients and too few doctors with the advent of what I'll call Romney care. I'm still fighting the last campaign. But the issue vanished after a few years. Now, some say that Massachusetts is not a good example for this because more than 90% of the people in that state had health insurance to begin with, unlike places like Texas and Arizona and New Mexico and California, where a quarter or more of their people are not insured. But here's the thing, and I don't know if you've heard these numbers before. Frankly, I find them very astounding. We need 45,000 more primary care physicians, over 1 million more nurses, and 40,000 more surgeons before my friend's grandchild turned 7 in 2020. This has engendered a topic for national discussion about the role of the nurse practitioner. Now, the two states represented here are in the forefront. You allow a lot of freedom and responsibility and accountability to your nurse practitioners, but that's not quite the case in most other states. How much autonomy to grant her? And it's usually a her about 95% of the time. How much supervision must she receive from a licensed physician, especially in a rural practice where her only link to the outside may just be telemedicine? Can she have full prescribing privileges, which many states currently don't allow? Now, this also came up in the last group. There's growing interest in the role of the ACO, the Accountable Care Organization. Will they really free up physicians to practice real medicine while augmenting their efforts by other trained professionals, or will it be merely rearranging the deck chairs on the Titanic? Now, I can tell you I went to a well-run ACO practice about 2 weeks ago myself, and they proudly had a poster explaining the concept of what they were all about in their office. And I realized it was actually a marketing tool for them and a practice builder, although they were pretty busy, but it was a practice builder. Now, one other thing that may also affect quality, I see it as usually a good thing, depending on how it plays out, and that's the new immigration bill. We've yet to see this thing. We've yet to see the new immigration bill. It may be introduced this week. They may be introducing it now, even as I speak with you. It's supposed to have provisions to allow in people with skills, perhaps qualified medical doctors who want to practice here once they're properly credentialed by us. We'll see. It won't be the first time that we've done this, not the first time that we've opened our doors to medical help from overseas. Shortly after World War II, we had a serious shortage of specialists in this country. And we helped to close that gap through our immigration policies. Also, GIs getting their GI benefits. Many of them were primary care physicians. They started to go back to med school and they specialized. It was very common when I was a kid to hear about the brain drain as other countries complained about our aggressive recruitment of their physicians, their mathematicians, their scientists, their engineers, and so on.